The pancreas is supplied by branches of the celiac trunk and of the superior mesenteric arteries. The veins of the pancreas drain primarily into the portal vein. In this very complex cast corrosion preparation, one can see the duodenum casted in white, and the head, body, and tail of the pancreas with the arterial supply and its veins. Note that we have the spleen above the upper pole of the left kidney. And we can see through the tail of the pancreas the left adrenal gland. Note that we have casted the veins of the adrenal gland and of the left kidney in blue. We can also see in blue the termination of the superior mesenteric vein. Note that the splenic artery runs along the upper border of the body and tail, and just caudal to it we can see the splenic vein. We can see the proximity of the left renal vein to the body and tail of the pancreas. And we can also see, as later will be better described, extensive venous communications between the body tail of the pancreas with the upper pole of the left kidney and with the left adrenal gland. This is another cast corrosion preparation showing the venous connections of the pancreas to adjacent structures. For example, the red arrow head shows a connection with the upper pole of the spleen. The orange arrowhead indicates the splenic vein. Note that we have slightly obliqued the specimen in order to show the left renal vein, above it the adrenal gland, and the venous connections are seen between the adrenal gland and the body and tail of the pancreas. We have ligated the renal vein, so we only see its proximal portion, which receives the left gonadal vein. This is a close-up of a cast corrosion preparation showing the proximity of the splenic vein to the renal vein. Also note that there are venous connections between the tail of the pancreas, the upper pole of the left kidney, and the left adrenal gland. This is a close-up of the tail of the pancreas. I stained in white the intravenous connections between the upper pole of the left kidney, the left adrenal gland, and the pancreatic veins. Large venous structures are seen between these organs. Another close-up of a cast corrosion preparation. In white are the veins that connect the tail of the pancreas with the upper pole of the left kidney and with the spleen. These are large venous structures that often are severed when a nephrectomy is performed and there is a tumor in the upper pole of the left kidney. Not only the normal veins can be transected, but because of the hypervascularity of a cancer of the upper pole of the left kidney, large venous channels are noted often surrounding the cancer. These are veins that are impossible to separate at the time of surgery from the tail of the pancreas and from the spleen. It is not uncommon to see left nephrectomies accompanied by selective splenectomy and sometimes even by resections of the tail of the pancreas because of the bleeding caused by the resection of these venous channels. It is wise to embolize tumors of the upper pole of the left kidney to decrease these perirenal venous channels and use less blood in the form of a transfusion when a selective left nephrectomy is carried out. We did this cadaver study injecting barium in situ into the portal system. Note the splenic vein that receives veins of the tail of the pancreas, which are perpendicular to the undersurface of the splenic vein. Also note the entrance of the inferior mesenteric vein almost at the angle of the splenic vein with the superior mesenteric vein. The superior mesenteric vein is the large channel seen to the right of the inferior mesenteric vein. Cephalad from the splenic vein and almost at the junction of the splenic vein and the portal vein is a very enlarged coronary vein. This patient had hepatofugal circulation due to portal hypertension secondary to liver cirrhosis. Note that from the tail of the pancreas we see two venous channels that are connected to the left renal vein. So we can demonstrate, therefore, in anatomical specimens, veins of the tail of the pancreas that can connect with the left renal vein. In another cadaver, we selectively casted the veins of the pancreas. The ventral and dorsal view of the body, head, and tail of the pancreas are illustrated. Note the large portal vein receiving the splenic and mesenteric veins. Note that the veins of the head of the pancreas drain into the portal vein and also some into the superior mesenteric vein. Note also that running along the upper edge of the body and tail is the splenic vein. We have not included in the specimen the spleen or the left kidney. The veins of the body and tail drain towards the splenic vein preferentially. So if one is to do sampling of blood from the body and tail, one would have to catheterize the splenic vein and enter some of these small veins, or simply sample blood from the splenic vein distal, proximal, or in its middle third. This is an axial view of the head and body of the pancreas. Note the portal vein, and note also that dorsal to the pancreas, we see the terminal part of the left renal vein, which terminates in the inferior vena cava. And just behind the left renal vein, we see the aorta. This is to show the proximity of the left renal vein to the pancreas. This is a sagittal section of another cadaver taken to the left of the midline. The patient's anterior portion is to your left, the dorsal part of the patient is to your right. Note the large adrenal gland just behind the tail of the pancreas. And note that running along the upper border of the tail of the pancreas is the splenic vein. And note that just below the tail of the pancreas is the left renal vein. What we have tried to demonstrate is the extensive venous connections of the pancreas with organs such as the spleen, left adrenal gland, and left kidney. Also to emphasize the proximity of the left renal vein to the body and tail of the pancreas. This explains how pancreatic disorders, be that inflammatory, pseudocyst, or neoplasias, can involve the left renal vein. And because of the proximity of the tail of the pancreas to the upper pole of the kidney, one may see masses in the kidney that are a reflection of a pancreatic disorder, be that pancreatitis, pseudocyst of the pancreas, or tumors. This is a nephrotomogram of a patient that had a pseudocyst of the tail of the pancreas. Note that the upper pole of the left kidney is enlarged, and also note that it is somewhat hypodense. At first glance, a mass of the upper pole of the left kidney was suspected. However, this mass proved to be invasion of the kidney from the tail of the pancreas, which had a pseudocyst. Signs of left renal vein thrombosis, particularly notching along the left ureter, are demonstrated in these next cases. This first patient is a patient with acute pancreatitis. Note that there is very fine indentation, that is notches, along the left and right wall of the ureter, and this finding corresponds to collateral periureteric veins secondary to left renal vein thrombosis. And as we have described previously, often a gradual obstruction of the left renal vein does not produce changes in size or function of the left kidney. So we should therefore look for collateral circulation to make the diagnosis of renal vein thrombosis. This patient had reversible notching, and upon resolution of the pancreatitis, repeat the urography revealed a normal left ureter. So renal vein thrombosis may be a reversible process. This patient had a pseudocyst of the tail of the pancreas. The urographic examination only reveals some notching along the proximal left ureter and poor visualization of the calyceal system. And the notching was really the only sign of renal vein thrombosis, which in this case was due to compression or to involvement of the left renal vein from the pancreatic pseudocyst. In this patient with chronic pancreatitis, we can see extensive calcification of the pancreas and non-visualization of the left pelvocalyceal system. And the non-visualization was the consequence of obstruction of the left renal vein. In this case, a decompensated left renal vein thrombosis. This is the left urinary tract of a patient with a carcinoma of the tail of the pancreas. Note the notching of the proximal left ureter, but observe that there is no abnormality as far as the kidney size or function. The venous phase of a celiac angiogram reveals total obstruction of the splenic vein, as indicated by the two arrows, just above the projection of the left renal pelvis. Note the persistent notching of the proximal left ureter. Note also encasement of the proximal portion of the portal vein. This patient had a non-resectable cancer of the pancreas. Another patient with a carcinoma of the tail of the pancreas revealed lateral displacement of the proximal left ureter. In this case, there was no notching, only a mass effect. What is the differential diagnosis? A tumor of the retroperitoneum that could be in the nodes of the high aortic chain, such as lymphoma or metastatic disease. This could have been a retroperitoneal sarcoma or even a tumor of the kidney extending medially. In this case, it was the tumor of the tail of the pancreas that displaced the proximal left ureter. This is a selective left renal venogram of the same patient with a carcinoma of the tail of the pancreas. Note that there is encasement of the left renal vein. Another sign that we could have expected would be notching of the ureter, and that may happen if the patient lives long enough to cause distension of the perirenal venous plexus. Note that there is a large capsular vein coming off the upper pole of the left kidney. This is a specimen of a cancer of the tail of the pancreas. Note that there is the complete obstruction of the splenic vein, and also note that there is a mass below the splenic vein, and this is a portion of the tumor that can invade or compress the left renal vein or even the left kidney. The last 6 slides are of a very interesting patient, a 69-year-old woman who was admitted because of aching pains throughout her body that were more severe in the back and in the right lower extremity. The physical examination revealed a slight splenomegaly. The patient had extensive workup by 2 gastroenterologists and a psychiatrist, and the working diagnosis was that she was a psychoneurotic patient. Part of a workup was an intravenous urographic examination. Note that there is a slight enlargement of the spleen, and note that there is a discrete density medial to the left kidney, just above the left renal pelvis. A nephrotomogram of the upper urinary tract shows a discrete nodule that is medial to the hilus of the left kidney. What is the differential diagnosis? Adenopathy might be a possibility. Another one that we might see a buckled vessel in this region. It could have been also a small tumor. This is the venous face of an abdominal aortogram. The spleen appeared slightly enlarged. In the hilus of the left kidney, we can see dilated veins. There was no visualization of the left renal vein. These dilated veins are the result of obstruction of the left renal vein with collateral circulation. Selective left renal arteriogram showed in the arterial phase normal arteries and normal renal parenchyma. In the photograph to your right is the venous phase of this selective examination. Note the buckled collateral venous channel indicated by the arrow, which represents a dilated juxta-renal vein and expression of collateral venous circulation. The patient had total left renal vein thrombosis. A selective left splenic arteriogram shows encasement of the proximal splenic artery, as indicated by the arrow. The bottom image is the venous phase of this selective splenic arteriogram. Note that there is no visualization of the splenic vein, that the spleen is slightly enlarged, and we can see a large left gastroepiploic vein, and some veins that are observed paralleling the splenic vein. They reconstitute and opacify the portal vein indicated by P, indicating that there was a complete obstruction of the splenic vein and antegrade periportal collaterals that filled in an antegrade fashion the portal vein. So in the presence of a splenic vein obstruction of the left renal vein, one has to think in pathology of the pancreas. At surgery, this lady had an extensive cancer of the pancreas, which was not clinically suspected. We are omitting the CT examination that revealed a non-resectable tumor of the pancreas.